The pipeline, uh, basically they figured out how this is working with the BDNF and the influence in the biochemistry. They're looking at things that don't have the side effect profile that ketamine does. Rapastanel essentially didn't seem to be efficacious and basically flamed out in phase 3 clinical trials. Dicycloserine, an NMDA antagonist, plus D50, that's, D2, 5-HT2 is coming up, and seemingly the receptor antagonist, is, possible coming to market, I don't know, in the next 2 to 3 years. As I was mentioning previously with the FDA approval for patients with major depressive disorder, specifically postpartum depression, brexanolone is an IV infusion, and if I'm not mistaken, it's 60 hours worth of infusion time. But it did receive approval by the FDA in March of 2019 for that patient population. So that's kind of the pipeline and what both industry, the pharmaceutical industry, as well as other people are talking about, basically trying to do a downstream effect with the efficacy of ketamine and without the side effects. To date, to the best of my knowledge and understanding in the literature, there hasn't been anything specifically identified that has met those criteria quite yet. But I know there's about 17 different breakdown products of ketamine that last for 10 to 17 days in the bloodstream, and they are looking at all of those different options. You're also seeing recently in the literature in the last 3 to 5 years treatment for alcohol withdrawal with ketamine infusions. That's beyond the scope of this grand rounds, but just wanted you to be aware that that was being used and studied. It's also being used and hasn't been studied as much or not published, withdrawal from multiple medications of abuse. But once again, those haven't been published to the best of my knowledge, so those will not be covered here. Wanted to leave a little bit of time for questions because this is a relatively new topic. We have approximately 15 minutes left of your very valuable time. But if you have any questions, comments, cares, concerns, issues, problems, or would like more information about the clinical element of things, now's the time to ask if you would like.
Dr. Oliver, I have a question.
Yes, sir. I'm sorry. Who I can't see you. Who are you?
I'm student physician Joshua Ryan. I'm a M4 student going into psychiatry.
God, welcome.
Thank you very much. You mentioned using midazolam to sort of mitigate the anxiety effects that can happen with the dissociative experience in ketamine, but I know earlier you'd also mentioned that benzodiazepines decrease the glutamate release and therefore blunt the responsiveness of the patient to the treatment. Have you seen that when using midazolam?
Yeah. So the reason and thank you so much for pointing out that and allowing me to clarify. It seems to be the long-term effects of taking benzodiazepines, which, we're talking Ativan, we're talking Xanax, Valium even, at higher dosages that last longer than the midazolam, the Versed lasts. Midazolam lasts approximately 90 minutes in duration. And for a half-life of approximately 90 minutes, versus the others can be 16 hours plus for the oral benzodiazepine. That being said, we haven't seen any issues with using that the Versed for patients with Versed for the patients with or decreasing efficacy. The efficacy is going to work either way. We do advise patients in the beginning. We do an initial consultation, which is very thorough. That includes the lab work. And when we're doing our review of both medications as well as alcoholism and polysubstance abuse, we have a conversation and explain to the patients, especially with high alcohol use as well as very high usages of benzodiazepines, to potentially work with their physicians to wean off of those medications so that we can be as efficacious as possible. That being said, these are relative contraindications and not absolute contraindications. That you can still give the ketamine and it can still be efficacious in that setting. But with a couple studies published from Australia, I think 2015 to 2017, showing that the benzos had affected this by the time we get the patients. I mean, it's pretty much critical care psychiatry. And when we get the patients and we do counsel them about that and give them full disclosure of that it could, chronic use of high dosages of benzodiazepines can affect, the efficacy of the ketamine infusions. We've also had patients who subsequently to doing our infusions, for a variety of reasons, went up on benzodiazepine usage. And when they did that, they absolutely had a decreased efficacy of, their issues. Have had similar issues with patients, female patients, changing birth control regimens. And their they were stable. They were stable for more than a year. And I was like, what changed? And you go back and you literally go through everything and see what the changes were, situationally or medicinally. And we've had issues with women's birth control as well.
Quick follow-up if I could then.
Yeah.
So is that something, like, just particularly with the benzos, because I was thinking, as you say, it's kind of like a critical care psychiatry. By the point you get them, they're not really probably going to be able to say, like, okay, over the next 3 months, let's try to wean you down if they're so acutely suicidal or, to need this intervention. So if you had a patient who's on like daily benzodiazepines to manage anxiety, is that something that can be maybe compensated for by using higher doses of ketamine? Is that something you've tried?
It can be. And so we would go up on that, and we differ from some of the how some of the studies have been doing, just because it's very difficult to design a study to track the partial disassociation versus us having done it thousands of times. We can do that, and we would normally use a higher dosage of the ketamine to try to overcome or overpower the chronic use of benzodiazepines. Some have been able to do it. As you probably know, even as an M4 level, the benzodiazepines, both in addictive quality as well as withdrawal issues, can be pretty staggering to get off of, and very challenging. So we have had patients, sometimes we do give a rescue infusion, which is one infusion when a patient is suicidal. The patient I'm thinking about now basically came back to us after pushing 6 months of weaning off of very high levels of benzodiazepines, and then had 6 infusions. Actually, I think went to number 7th and number 8th and had a pretty significant improvement of his symptoms and complete resolution of any suicidal ideation.
Thank you, sir.
Thank you so much for your time. Anybody else might have any questions?
Dr. Oliver, I had one question. I really appreciate your dose response timeline regarding the patients who had depression, including the patients who had PTSD. I guess on that y-axis there, was that the PHQ-9 that you were measuring over time with treatment?
Yes. Let me go back up. I'm assuming you're referring to these charts.
The one that had different colors on it.
Yeah. So that's PHQ-9, and from 0 being at the top for none, 0 to 5 being none, to severe being as high as 27 or as low on the chart as this patient was on the July. We use a PHQ-9 because A, it doesn't cost $3 like the Beck inventory does per usage, and B, we found it to be pretty efficacious in tracking people's moods the overwhelming majority of time, like 95+% of the time, tracking very well.
With, I guess, the PTSD, did you notice like any change in their intrusive symptoms like nightmares, flashbacks with the treatment, or was it more just with the depressive symptoms?
Yeah, no, so it is with the PTSD related symptoms. The PTSD is very interesting because, and the way I tend to think about it is the PTSD from whatever the case may be, whether it be a car accident, whether it be a sexual assault, whether it be a trauma, whether it be a military based, there was a grenade in the Humvee, and these are all things that we have seen in our practice. Um, they seem to have a physiologic change in their brains and how they deal with things. The ketamine seems to, especially when they disassociate, seems to be able to compartmentalize whatever happened. They don't forget about it. It's not necessarily less intense, but they seem to have a greater perspective for how they approach it. So as opposed to like hearing, the backfire of a car, or a very loud noise and thinking gunfire, they're like, that's probably the backfire from a car or an issue like that. Um, it has seemed to have profound effects on the PTSD population, in both studies as well as our experience. We're located right next to the Pentagon and in the middle of Norfolk, which is the world's largest naval base, if memory serves. So we do have multiple military and PTSD affected patients, and they truthfully have seemed to do very well, especially when we get the disassociation levels right of partial disassociation.
Sure. Thank you, Dr. Aller.
No problem. Anybody else might have any other questions or issues?
Oh yeah, I'm Dr. Gill. I'm one of the psychiatry residents. I don't know if you'd gone over this before, but now with it being FDA approved, previously being off label, can you just treat anyone that kind of comes in and meets the criteria, or do they undergo any? Do they have to be treatment resistant, have failed a bunch of other trials of other medicines, or can you go straight to that if that's what the patient's agreeable to and you think it's a good fit?
Yeah, so that's a great question. With it being, a class 3 medication, I think that there are, especially in the first 20 years of this, has been an abundance of caution, which is specifically the reason that it was used for treatment resistant patients. That being said, I have treated a handful or two of patients who didn't have other previous treatments, either situationally or what have you, and have had profound success with those patients. That being said, I am not a psychiatrist, nor am I trained to do the chronic medical management of these patients. So I normally defer to psychiatry as far as the treatment plans are concerned. That being said, the simple version is it works. And I don't think it has anything to do with anything other than physiologically it works. And if it works, I mean, even though it's not FDA approved for that indication, as well as ketamine just not being approved for this indication, I think it makes sense to treat them. I mean, what you're talking about is the difference between relief of symptoms within hours to days versus 6 weeks to 2 months, and profound numbers for ketamine for an increase. I mean, I think it should be considered. And I think the other thing that really should be considered, and I haven't heard anything about this yet, but with it being approved by the FDA for acutely suicidal patients with major depressive disorder, are you going to have an issue, similar to emergency medicine has had with TPA? Is if this medication is not considered and or offered, is that going to change, the FDA approval? Is that going to change the standard of care? Because right now the standard of care, at least primarily from what I can see from the Department the emergency department perspective and the emergency medicine perspective is patients come in, they sit and are often held in our emergency departments for really obscene amounts of time, 24 hours, 72 hours, etc. And not only are they occupying an emergency department bed, and if you've been in the emergency department, you probably know enough to know that it's an interesting environment, to say the least, and probably not the most conducive to somebody who is suicidal and or majorly depressed. I think we're going to, the realm of psychiatry and the psychiatry interaction with emergency medicine and specifically suicidal patients, I think we're going to be hard pressed not to consider this and potentially offer it to patients who meet criteria, that there's nothing else that we are using to treat presently. And if that's the case, I'd probably say to go to at least 3 infusions or resolution of symptoms. But should absolutely at this point in time also receive inpatient admission to the psych inpatient for further evaluation, observation, and treatment. Did that answer your question?
Thank you very much. Yeah, it does. Thank you very much.
Thank you. Somebody else coming in with a question or two? We got another 2 or 3 minutes.
I guess from your experience with IV ketamine compared to Spravato, and I guess, obviously the bioavailability probably makes a difference, but I don't know, from your experience, have you noticed any difference with like side effects, with blood pressure side effects, GI side effects between the two based off of like bioavailability?
Haven't really had many, if any, GI side effects. That being said, with the bioavailability, the experience normally is not as intense as the patients. When the patients say that, they're experiencing this, it's not as intense when they take the Spravato versus the IV ketamine. And that probably has to do with the route of administration. The patients, I've had some patients that have originally tried the infusions, and for whatever reason, either needle phobia or whatever, they've tried then the Spravato. One patient did have more success with the Spravato than the IV infusion. But normally when people come to me and they've tried Spravato and now they want to try the IV ketamine, they normally seem, especially if they can tolerate the IV access and the starting of the needles, they normally seem to say that the IV works better, works longer, and is more efficacious than the Spravato is. Well, if there are no more questions or comments, cares, concerns, I just want to thank you so very much for allowing me to speak with you. I hope that if you have any questions, please don't hesitate to reach out. I'm happy to answer anything. This is all my contact information. And if you would go to mindpeaceclinics.com, that might help to answer some of your questions on a regular basis. But if you have anything else and you're like, hey, I just want to run something by you, please don't hesitate to reach out. There's probably, a handful of providers, no more than 10 throughout the Commonwealth of Virginia that are doing this. I'm the one that's done this, probably done more infusions than anybody else. The efficacy and the safety which this medication works, albeit with some side effects for some patients, really makes this very well tolerated, and some profound, very rapid resolution of the patient's symptoms. But thank you so very much. I hope you guys have a great day. And if ever I can be of assistance to you, please don't hesitate to let me know.
Thank you. Have a good one.
Dr. Oliver.
Have a great day.